Hi, I'm Brian Rini from Vanderbilt-Ingram Cancer Center. I'm here at the GU Oncology Now ASCO roundtable with my friends and colleagues, and I'm going to let them introduce themselves. We're going to talk about frontline kidney cancer and then also talk about refractory kidney cancer incorporating the latest data. Tian?
Hi, everyone. I'm Tian Zhang, an associate professor at UT Southwestern Medical Center. I'm really glad to be here today.
I'm Pedro Barata. I'm also a GU oncologist at University Hospital Sideman Cancer Center, Case Western in Cleveland, Ohio. Also very happy to be here.
And I'm Michael Atkins, a medical oncologist and deputy director of the Georgetown Lombardi Comprehensive Cancer Center in Washington, D.C., and I'm delighted to be here.
Thank you all for coming. Let's move on to the refractory setting. We've started to touch on sequencing. So, Tian, maybe I'll talk with you. At ASCO, we saw results from CONTACT-03. There's a Lancet publication same day, and this was basically Cabo-Atezo versus Cabo in an IO refractory setting. Patients had to have IO as their most recent therapy. I think about half had Ipi-Nivo, if I remember. So it was a pretty typical for everything we've been talking about, right? A lot of Ipi-Nivo, a lot of IO-TKI, so I think fairly typical. Very few adjuvant patients, which we can talk about, I think one in each arm. But it was really built on, can patients get sequential immune therapy? Is it of benefit? Do they have what I would consider as another shot at cure with immune-based therapy? There was some data with lenvatinib, pembrolizumab in a single-arm study that looked pretty good, right? Response rates in the 50+%. I think PFS was, 11, 12 months. So when I saw that data, I was like, well, pretty good for immune refractory patients, right? Then the len-pembro frontline data came out, and maybe it's just a more potent regimen from a tumor shrinkage standpoint. But be that as it may, and this was happening in practice, right? I'm sure we were seeing this, and in roundtables like this, people would give IO-TKI after Ipi-Nivo, et cetera. So this was happening based on that len-pembro data or other data, but now we have a big randomized trial that shows no difference, right? The Cabo monotherapy arm did tremendously well, and we can talk about that, 10+ month PFS, response rate of 40%. And it was, all the curves are overlapping. I mean, the data is absolutely identical. It couldn't be more negative. There's not even a hint of some advantage. And importantly, there were 3 toxic deaths in the IO-TKI arm, right? So the 2 drugs in the IO is not without consequence. So Pedro, maybe I'll start with you this time. Reaction to the data.
Sure.
What were you doing before, and does it impact your practice?
So I think the data is important, right? And so it's not a coincidence that we see it out at Lancet Oncology as a practice-changing study, right? I think that information is relevant. And to your point, a lot of us were doing IO with a PD-1, right? Mainly with a PD-1, I think, until the data was out. And actually, it's interesting because you go back, when we start trying to figure out what was the role for CTLA-4 inhibitor, right? A lot of us were giving a chance at different lines of therapy very late in the game, and we quickly realized, well, not that quickly, but we realized that perhaps the right role for a CTLA-4 inhibitor is up front, right? And I think we understand that, but we didn't quite know the same with the PD-1, right? Now here's, patients progress, to your point, they progress on a prior checkpoint, and CONTACT-03 couldn't be more negative. I think there's a couple of comments that we'll have from folks out there. So the first is, right now we have no data that supports the use of salvage checkpoint inhibitor if you've progressed on a prior checkpoint inhibitor. And I'm not sure if you can apply that necessarily to patients who will be getting more and more adjuvant therapy. They complete 1 year of immunotherapy with pembro, and then you recur a year or 2 later. I don't think we know that for a fact, but at least for patients progressing on a frontline IO, I think right now we have no data to keep supporting that as moving forward, and at least until other trials like Ipi-Nivo will read out. Now, there's a couple of comments that we can make about the design. First of all, I think it was the first design to keep the same control, the backbone in both cohorts. So other trials out there exploring salvage IO are comparing it against something else. This one compared Cabo is in both arms, and I think that's important because it puts into context. I think one point you just say that you mentioned it quite well. Cabo did perform quite well in the control arm. The other point is, for whatever it may, we have data that perhaps asks the question, do we really believe in PD-L1 the same way we believe in PD-1s? PD-1s are different from CTLA-4. I'm not quite sure PD-L1s are the same as PD-1s. So I guess if we were to redo that, we probably would have chosen a PD-1 instead of a PD-L1. We don't know that. Maybe the Ipi-Nivo will help to answer that, at least in part, right? So that will always have that comment. My other editorial comment about that data would be, we haven't seen that data. I believe there were some thoughts about it. There's an heterogeneous population. Some are primary progressors on IO, we did not exclude those patients, on the trial. Those other patients can stay on therapy for 2 years, right, and then go on trial. And so, to my understanding, I have not seen a pure breakdown of, was FLAT negative for everybody, or are we, for the way we enroll in this particular trial, patients who went on a second-line CONTACT-03 were actually, they progressed within a year, let's say, or 6 months, right? And then you don't see that because those patients are less likely to benefit from IO in salvage. I'm not saying that's the case.
Yeah, I don't think there was, thinking about the forest plot, I don't think there was any.
Right. I don't think there's a signal there,
yeah.
But at least, hypothetically, right? Because that opens the question, are you done as when you try a checkpoint inhibition once, or do you need a break from that MOA and to revisit that in the future? I don't think we know that.
This trial doesn't answer that.
That trial does not answer that. So I think those are the remain unanswered questions for the future. But I will finish as I started to answer your question. I do believe it's a practice-changing trial because I do believe that's going to give a lot of pause to folks out there to stop using an IO in the salvage setting for patients progressing on frontline IO.
Mike, what do you think?
I agree. Very important trial for the reasons that Pedro said. I think a couple of points, just so that people don't over-interpret it or misinterpret it. I think that it doesn't mean that immune therapy won't work in the second line, but we've always taken the approach that if you want to have immune therapy work in the second line, you have to add something that's another immune therapy to it that's effective. And then it's a good idea to keep anti-PD-1 around, because if you're activating the immune system in another way, you want to make sure it doesn't get shut off by having PD-1 expressed or PD-L1 expressed by the tumor. And so I don't think the interpretation should be you only get one shot at an immune therapy. You could say Cabo is not an immune therapy. And second point is that the Cabo activity was better. And I've heard people say maybe that was because there was leftover immune therapy. And so you were actually giving IO-TKI even in the Cabo arm. But I don't think that's the case. I think there's not enough consideration of how the second-line patients are different than the first-line patients. And the second-line patients who've had prior IO are relatively depleted in patients with aggressive disease who might have potentially responded in a major way to the front line. And if they didn't respond, they never got to this trial. And so you have a second-line patient population that is more TKI responsive. And that's why the Cabo response rates are, you would call, surprising and better even than what you saw in Meteor, and a little better even than what you saw in Cantata. Yeah.
So you think the immune responsive subset's depleted and the angiogenic responsive therefore is enriched. Yeah, and that's leading to the results.
Well, to that point, I mean, there were that cohort, right? So this second line therapy patient cohort, to your point, is quite heterogeneous. So they received in the frontline setting and how they responded in the frontline setting and how they're progressing, timing of progression, where they're progressing. Those are all patient characteristics that as clinicians we think about when we're selecting subsequent therapy. But as they're enrolling into a trial that was designed this way, everybody is sort of randomized and treated the same way, which is great for trial design. But suffice to say that this cohort is very different, right? The Ipi-Nivo treated frontline patients, they were never exposed to a VEGF TKI in the frontline. And so this patient, 30-40% of patients are not the same as the Meteor patients who had VEGF TKIs in the frontline and then went on to Cabo. So that is a, TKI naive cohort that I bet if you looked at the stratification factors in the cohort, those were probably the patients who did really well on the cabozantinib control cohort. And so that drives the difference a lot less than we possibly could have expected if those patients were taken out of that comparison. I don't believe we see that in the current data that's public. But I think it's an important trial. I was one of the proponents of using Len-Pembro from the Memorial data, and in the refractory setting. But now that CONTACT-03 is out, I think thinking about the change out of mechanisms of action, I think is appropriate. If people have had ipi/nivo up front, they can do very well on cabozantinib monotherapy. I won't add atezo. Certainly want to wait until T-nivo 2 reads out to think about that again. But that sequencing is an important one, and in one way it's a part of Pedigree 2 is thinking about that sequence of ipi/nivo followed by cabo. But then also, if you take a break, right? So I wonder if you take a break, say they received axi-pembro or they received ipi/nivo up front, and then they get cabozantinib alone. In that third line, could people, and they've had 9 months or 12 months for their T cells to repopulate and the exhausted T cells to go away, could they be again responsive to PD-1? I wonder what you think about that.
I guess my opinion is it's possible. I wouldn't do it in practice because there's no data to support it. And I don't know that trial is going to get done.
How is that trial going to be done, right?
Because I don't know that trial is going to be done. I'd love to see it.
Yeah, multiple
and
years.
We've been talking about
Absolutely.
Nivo, which is tivozanib nivolumab versus tivozanib, and Nivo is a PD-1 inhibitor versus PD-L1, so that may be a mechanistic difference. I know that did allow prior adjuvant therapy, and there will be more because I know we put several adjuvant. I don't remember if they had to be within 6 months. I don't remember quite the parameter, but it will give us a little insight into that question, which we've been alluding to, is, well, gee, what if 2 years have passed since your adjuvant therapy? Like, we all think, well, we probably would start over with that patient, but we don't know, right?